for a patient to be a candidate for surgery, they have to have a body mass index of greater than 40 or a body mass index of greater than 35 with established comorbidities. Comorbidities are conditions like diabetes, high blood pressure, asthma, obstructive sleep apnea. So that is the definition of what morbid obesity is. Either it'll be restrictive, where you're basically restricting the size of the stomach, or it will have a malabsorptive component where you're actually bypassing a portion of the intestines. So since most of the calories are absorbed in the small intestine, if you bypass a third of the small intestine, you'll have lesser absorption of calories. In a gastric bypass, it's a combination. You have a restrictive component and you have a malabsorptive component. So you have two mechanisms of weight loss which are working. The laparoscopic gastric banding and the sleeve gastrectomy are purely restrictive operations. So there's no malabsorptive component, there's no rerouting of the intestines. They're purely limiting the size of the stomach. So they fall in the purely restrictive category.
Another procedure you do is called the gastric sleeve. Explain to me what that is.
The sleeve is a relatively new procedure. It is in the same category as the band. That is, it is a restrictive operation. So there's no bypass involved, no rerouting of intestines. The shape of the stomach becomes like a sleeve. So it's a long tubular sleeve. So that's essentially why the name sleeve gastrectomy. So it is a permanent removal of that portion of the stomach. It appeals to certain patients who are not desirous of having a foreign body put in them and are not desirous of coming back for their adjustments. In a sleeve, once the procedure is done, the patient does not have to come back for any adjustments like the band patients do. The fact that it's permanent, it's not reversible, and they can enjoy the benefits of it for the rest of their lives.
Are there any risks to these procedures, doctor?
There's certainly drawbacks to any surgical procedure which we do. First of all, there are certain risks which are common to almost all procedures which we do surgery on the obese patients, which would be cardiac complications or pulmonary complications like blood clots going to the lungs. So that is why we really want to make sure that these patients have been optimized prior to surgery. It is a procedure which is done laparoscopically, and what you're doing is you're using a mechanical device, which is a surgical stapler, to march up and remove about 60% of the stomach. So you're basically excising that portion of the stomach. In that sense, it is a restrictive operation where once you consume a certain amount of food, you'll get the feeling of fullness and stop eating. So it is a restrictive operation.
You know, we keep talking about laparoscopic surgery. Explain to me what laparoscopic really is.
Laparoscopic surgery is really a mode of access. The surgical procedures which we're performing were mirroring exactly what we would do when we would do these procedures open. The main and big difference is that instead of a patient being cut from stem to sternum, now we're able to do these procedures with small incisions, and in certain select patients and select procedures, we can now do them with just a single small incision. It really is not about looks or vanity. It really is about getting their health back. The vast majority of patients will be completely off all medications within the first 6 months of having the surgical procedure done. I'm a very strong believer in educating the patient. When a patient asks me, well, Dr. Vohra, what do you think, which is a better procedure for me, a banding, a bypass, or a sleeve? My standard answer is, I'm not going to make the decision for you, but I'm going to help you make the decision. So I think it really starts with educating the patient. We mandate in our program that they have to attend one of our educational seminars, which we offer on a regular basis, and they're certainly free. And we make it convenient for the patients, so we hold them in different locations so they can access it. They come to our comprehensive seminars where we educate them on the surgical aspects, the nutritional aspects, and then give an overview of what the whole process entails. Then encourage them to attend one of our support groups so that they can meet patients who have undergone the surgery and then get first-hand information as to what to expect in the first week, in the first month, in the first years. Let them assimilate all that information and then make an informed decision as to what would really suit their needs.
You know, once you've had that procedure done, is it possible to actually gain weight again?
It's the good news and the bad news. Good news is you're going to lose the weight. Bad news is there is no other way short of incorporating exercise in order to keep the weight off. I call it my Sunday rule. If during the week you're certainly going to have fluctuations in your weight, patients are going to socialize, people are going to socialize, and on occasion you may gain a pound or two. So I weigh myself every Sunday morning and encourage my patients to do the same. If they feel that they have an extra pound, and then certainly can exercise more and limit the caloric intake so that they don't really carry it over. This is a transformation. It's a rebirth for these patients. The gratitude which these patients express is far beyond the gratitude which we see for all other procedures which we do. Certainly those patients are very grateful, but to them this is a rebirth. You just gave them their life back, and they just say, this is now the first day of the rest of my life, or my new life. So they're excited about their appearance, they're excited about their new wardrobe. Simple tasks, they can tie their shoes or sit in a plane without being uncomfortable or having to ask for an extender. Be able to go into any waiting room and sit in a normal sized chair. So things which we all take for granted are certainly now within their reach.
Dr. Vohra, how do you describe your practice?
I do laparoscopic surgery, and we offer a wide variety of surgical procedures laparoscopically. Predominant part of our practice is bariatric surgery, which is a surgery for obesity. There we offer a range of procedures including the gastric bypass, laparoscopic gastric banding, sleeve gastrectomy, and some revisional surgeries. We also offer a whole variety of other laparoscopic procedures, including removal of a gallbladder, repair of hernias, treatment of gastroesophageal reflux, and removal of the colon for benign and malignant disorders. Almost 100% of the procedures we do are approved by insurance.
You know, you've been doing this a long time and on a lot of patients. You still love your job? You like what you do?
I love what I do. I really, truly love what I do. As I said, it really is the most rewarding aspect of my career. It is very demanding, but absolutely the rewards are well worth all the efforts involved. I'm also blessed with a wonderful team because, as you know, you're only as strong as your weakest link. So this is truly about a team approach and having a team which makes everything look easy.
And there you are, some very important and beneficial information on the subject of weight loss surgical procedures and laparoscopic surgery from Dr. Rajeev Vohra. I'm Doug Llewellyn reporting from Long Island, New York.